It was Straightsmile Solutions, straightsmilesolutions.com. And recently I got asked this question, which was, how do you know if you're going to have success with a canine expose and bond case? Should I even take this case? Um, or how do you know if there might be risks? And the answer is you don't always know. And that's the thing is, even as an orthodontist, we really don't have a choice. We got to take all the cases and just go for it. And if they don't work out, they don't work out. Obviously, I always have some additional supplemental informed consents that if I think it's going to be less likely that it's going to be successful, that the patients and the parents sign. Although I've been burnt on once before where everything was done right and it turned out it was just ankylosed. 20 years ago we really didn't have access to CBCTs like we do now. So I mean, my number one suggestion is take a CBCT if the root is fully formed, or if it's an adult 18 and up. I personally recommend taking a CBCT before you start. That would be number one suggestion. Why? Because yes, you can take a couple PAs with a shift and kind of see the position and kind of see the PDL. But a CBCT is the gold standard to know if it's ankylosed, and not only take the CBCT, but also have it officially read by a dental radiologist to rule out ankylosis. By doing that, at least I know that there's potential for movement. So that would be the first thing. Again, if it's not crazy, and if you have access to my Phase 1 Smile, which is a document that sometimes I give away, but I do sell in my document store, or if you are one of our clients, even if you've purchased any of our courses, attended any of our recent webinars, it has to be within a few days, happy to give it to you. We go over the different types of canine impactions, how severe they are, how to measure, angulation, things like that, which gives you some idea of the severity. Obviously, something like this, which is horizontal, and overlapping a lateral, is more severe than horizontal and not overlapping a lateral. This one might probably transposed, so never mind. Transposed is a whole different thing. So we're looking at where root tip position, we're looking at overlap of the adjacent teeth, and we're looking at angulation. So obviously these are a hot mess. So we won't even go there. But yeah, CBCT is a great suggestion. Number two, like I mentioned, is the root apex formed? If it is not formed yet, then there's definitely much more potential for spontaneous eruption and correction, and it's very unlikely to be ankylosed. So that kind of correlates with age. If the patient is 16 and under, better outcome than older, and then from there, the older the patient is. If they're in their 20s, oh, forget it. Highly unlikely these things are going to happen, or much more likely to get root resorption damage, ankylosis along the way spontaneously, etc. Age, position, so all these things come into factor, and then just the mechanics is a big thing too. How do we bring this in without banging the other teeth? Obviously, this is a 2D rendering, but in the 3D world, I mean, is this buccal? Is this lingual? Is it going to bump this tooth as we come down? Is it going to bump this tooth as it come down? I mean, these are obviously transposed, but you get the idea. Unless you have access to the right technology on a regular basis throughout the treatment, you probably shouldn't be taking that case, because you're going to have to take a lot of x-rays as you go. And if you don't, and even if you do, you can damage that tooth and other teeth. So even if you manage to do it, are you going to get a good outcome? Is the root going to survive? Are the root of the adjacent teeth going to survive? And a lot of times they don't. And if you don't go over those risks with the parent or the patient, they're going to be pretty mad if they lose a tooth or lose other teeth, especially if you could have just pulled that tooth out to begin with. So you got to go over all the risk, benefits, and alternatives. Also, you need to let them know that you're not doing the exposure. Gosh, I hope you're not doing both. You really should refer them out for that to someone who does this routinely. And that's going to be an additional fee, which may or may not be covered by insurance, as well as any follow-up visits or any debonds, because sometimes they do debond and they need additional surgeries. It happens. So you got to go over all of that. Lastly, you got to remember that the expose and bond should be done after initial 11 line is done and space is created, which could easily be 9 months, 12 months, or 15 months into treatment. It doesn't happen right then. You got to make the space first and get all the teeth around it ready to go and upright, so that you can have a clear shot to bring that tooth in. So a lot of times parents are just like ready to go with the exposure, and it's going to happen when the time comes, and when the time comes, you got to go do it. So they need to be flexible and ready to get that surgery when the time comes. Obviously, you're going to give them a heads up, but it's always a great idea to send them initially first to the periodontist or the oral surgeon to get a consult before you even accept the case, just to make sure they know who they chose, they know what the price is. Because I've had this happen so many times where, yeah, we're gonna get it done, and then we go to get it done, they're like, oh no, it's too expensive. Can we just take it out instead? Or can we try to close the space? You know? And I'm like, whoa, we just went the whole other direction for a year and a half. So we want to make sure they're fully committed to that process before we even get started. So same thing with jaw surgery cases or anything else. So hopefully that was helpful. Pick very carefully, pick very wisely. And even better if you can mitigate the damage, get these cases started on phase 1 earlier, and maybe this won't even happen. All right, thanks.